So hi everyone, welcome back to my channel Connect Radiology, where I'm trying to make the topics easiest for you to understand. So in this part 3 video of carcinoma rectum series, I'm going to discuss about the N and M staging of CA rectum and also few words about restaging after neoadjuvant therapy. So the lymph nodes for CA rectum are divided into regional and non-regional lymph nodes. Okay, so this regional lymph nodes include the mesorectal lymph nodes, the high mesorectal lymph nodes, that includes the lymph nodes in the mesocolon of distal sigmoid colon, okay, the presacral lymph nodes of inferior mesenteric and superior rectal vessels. Okay, so this is mesorectal. Next is high mesorectal. These are especially in cases of high CA rectum, which includes the lymph nodes in the mesocolon of distal sigmoid, presacral, the inferior mesenteric and the superior rectal vessels. Along these vessels, the lymph nodes. And the next group of regional lymph node is actually the extra mesorectal or lateral lymph nodes. Okay, these includes the obturator and the internal iliac lymph nodes. Okay, and next one are these: the common iliac, the external iliac and the inguinal. These are the non-regional lymph nodes. Why to differentiate these two groups? Because regional lymph nodes involvement is N stage, while the non-regional lymph node involvement is M stage. It is considered as metastasis. Okay, so we have to mention about the highest level of the high mesorectal lymph node, especially in cases of high CA rectum, because these are not routinely resected while doing the total mesorectal excision, or not routinely irradiated while giving the radiotherapy. So we have to mention the highest level of these lymph nodes. So these are also covered by surgery or the radiation field. Okay, so we have to mention this. Next thing is this extra mesorectal and the lateral group of lymph node. These are also, we have to mention this because these are also not routinely resected while doing the total mesorectal excision or while performing radiotherapy. So we have to report this to ensure there is no recurrence. Okay, so we have to remove this also while doing the surgery, or we have to irradiate these fields also while doing the radiotherapy. And these extra mesorectal lymph nodes are especially involved when the tumor is below the level of anterior peritoneal reflection. Okay, so the high mesorectal in cases of high CA rectum, and these lateral in cases of tumors below the level of anterior peritoneal reflection. Next thing is this non-regional, included as metastasis, the common iliac, the external iliac and the inguinal lymph nodes. One thing I would like to mention here, that this inguinal group of lymph nodes is an exception, because when there is low CA rectum, that is distal involvement of distal anal canal or part of anal canal which is below the dentate line, these inguinal lymph nodes are considered as regional lymph nodes. Okay, in high CA rectum these will be non-regional, but when the tumor is involving the part of anal canal distal to the dentate line also, then these inguinal lymph nodes are considered as part of regional lymph nodes. Okay, so we can see here these are the external iliac, the red one. This blue one is the obturator group of lymph nodes. This is the internal iliac, green one, and this is the mesorectal. One thing I would like to mention is how to differentiate. What's the point of demarcation between these? So the posterior border of this external iliac vessel is considered as the posterior border of this external iliac region lymph nodes. Okay, the posterior border of external iliac vessels. Next, how to differentiate obturator versus internal iliac? So the point of demarcation is the lateral border of internal iliac main trunk. Okay, so like if this is the internal iliac main trunk, then the lateral border is considered, okay, so this is the internal iliac. The lateral border is the point of demarcation. Lateral to this will be obturator, and here it is the internal iliac. So this is the point of demarcation we have to like remember. And these purple ones are actually the high mesorectal lymph nodes along the inferior mesenteric vessels. Okay, so what's the criteria for mesorectal and high mesorectal? Okay, so this is mesorectal as well as high mesorectal lymph nodes. Size is very important for CA rectum lymph nodes. So more than 9 mm is considered suspicious. 5 to 9 mm is considered suspicious if there are more 2 malignant characteristics, and less than 5 mm are also considered suspicious if there are 3 malignant characteristics. What are these malignant characteristics? Malignant characteristics includes the indistinct boundaries, the heterogeneous appearance, and round shape. Okay, these 3 are the malignant characteristics. Remember, mucinous lymph nodes, like very hyperintense on T2 following the tumor signal, are always suspicious. So this criteria is for mesorectal and high mesorectal. What about the lateral group of lymph nodes? So here there is no morphological criteria, only there is size criteria, and that is more than equal to 7 mm. If there is any lymph node in the obturator or the internal iliac region, it is considered suspicious. So let's talk about the end stages. So in end staging, 1A is only one suspicious regional lymph node. See, this regional lymph node includes the mesorectal, the high mesorectal, as well as the lateral lymph nodes. B is 2 to 3 suspicious regional lymph nodes, and C is presence of regional tumor deposits. Okay, these are deposits. Then 2A is 4 to 6, and 2B is more than 7 or 7. So 1, 2 to 3, 4 to 6, more than equal to 7. So what about the tumor deposits? How to differentiate whether this is tumor deposit or lymph node? So tumor deposits are more of irregular shape, and these are usually along the vessels. Okay, while the lymph nodes are still more of round or oval shape, and they have a capsule that is typical of lymph nodes. Okay, so let's see this case here. So here there is one lymph node, one obturator region lymph node, and this lymph node was not mentioned in the report, so not treated also. And what after the treatment, this lymph node which is left has caused the recurrence here. In this sagittal image, we can see multiple tumor deposits. Okay, so this is the story of regional tumor deposits. Now next is the M stage of rectal cancer. So 1A is mets to one organ. Okay, and mets in or involving the paired organs like bilateral lungs, bilateral kidneys, bilateral ovaries is still 1A. B is 2 or more organs, and C is peritoneal metastasis. Okay, with or without organ metastasis. A is one organ, B is 2 or more organs, and C is peritoneal mets. Remember, we have talked about the non-regional lymph nodes. Okay, so involvement of this non-regional lymph nodes is taken for a single organ. Okay, and single organ is given as M1A stage. Okay, so this is all about the N and M staging. Okay, and next we are going to discuss about the response assessment. So whenever for CA rectum neoadjuvant therapy is given, after this neoadjuvant chemo radiotherapy, the size of the tumor decreases and the tumor is replaced, is transformed. A fibrotic transformation is there. Okay, size decreases and fibrotic transformation is there. So after what's the response after neoadjuvant therapy is actually this response assessment is graded, okay, and this is known as the MRTRG, that is MRI tumor regression grade, and this is graded on T2MR images. We have to grade the degree of fibrotic transformation on T2MR images using this 5 scale, okay, using this 5-point scale. So one is complete or near complete, one is good, one is poor, okay. So in complete or near complete, there is for grade 1 there is normalized wall, okay, there is no tumor signal or there can be some thin fibrosis. And remember, for after neoadjuvant therapy, DWI is a very important sequence, because if there is any viable tumor after neoadjuvant therapy, it would show restriction on DWI images. So whenever there is complete response, there will be no focal diffusion restriction. Another is complete near complete grade 2, where there is no tumor signal but the residual fibrosis is dense, okay. Since there is just fibrosis, there will still be no diffusion restriction. Next one is the good response, where there is predominant fibrosis present but there are scattered or focal areas of tumor signal, okay, and these will be seen as scattered spots or small foci of diffusion restriction, means there is some viable residual tumor is still there. And one is poor, where in 4 grade there is predominant tumor signal with minimal fibrosis, and 5 is there is solid tumor only with no signs of fibrosis, and there will be mass like diffusion restriction. So this is the MR tumor regression grade, which is graded using a 5-point scale. In restaging after neoadjuvant therapy, we have to talk about 3 things. One is the response that I already have talked, that near complete or complete, good or poor response, okay. One is response. Next is the MRF involvement. This response is seen via DWI, okay. Next is the MRF, we have to mention whether the MRF is involved or the MRF is free, okay. So whenever there is less than equal to 1 mm distance between the solid tumor remnant and MRF, MRF is involved, and whenever there is major fibrotic involvement of MRF is said to be involved, okay. And when there is more than 1 mm distance between the tumor or fibrosis and MRF, and whenever there is minor fibrotic stranding contacting the MRF, MRF is said to be free. And another we have to mention in our reports is about the lymph nodes, okay. So lymph nodes are better seen while doing the restaging, because lymph nodes just disappear after neoadjuvant therapy. So the size criteria is more than equal to 5 mm, okay. There is no morphological criteria here, just the size criteria. 1 is 1 to 3 lymph nodes and 2 is more than equal to 5 lymph nodes, okay. For the lateral group of lymph nodes, there is no validated criteria, but still, if you ask me, it's 4 for the internal iliac group of lymph nodes, and the size criteria is 6 for obturator group of lymph nodes. Okay, so let's see these images. So here, let's see, there is this tumor on T2 before neoadjuvant therapy, and after neoadjuvant therapy, what you can see, there is this dark T2 hypointensity, which is fibrosis, and when you see on DWI, there is still some diffusion restriction, means there is some residual tumor is still there, okay. So DWI is a very important sequence while doing the restaging. Let's see another example. Here there is involvement of this MRF along 4 to 8 o'clock position, and after this neoadjuvant therapy, the tumor is retracted away from the MRF, thus MRF is free from the lesion after neoadjuvant therapy. And we already have learned in part 2 that whenever MRF is involved, the chances of recurrence is very more, okay, chances are very high. But after neoadjuvant therapy, as the MRF is not involved, the chances of recurrence are low, okay. So here is our multiple lymph nodes in the pre-sacral region, and after chemoradiation lymph nodes have significantly disappeared. So for example, in this case also there is this T2 intermediate signal lesion, but after chemoradiotherapy fibrosis has happened, and we have to look for the diffusion for any residual tumor or not. For example, in this case also the patient has undergone abdominoperineal resection, and there is intense fibrosis you can see here. This is all about the nodal and metastasis of rectum and the response after neoadjuvant therapy. I hope I did justice to this topic. With this, we are ending it here. If you have any doubts, you can ask me in the comment section, and we will meet again in my next video. Till then, tata, bye bye, good night.